Well, it's good to see you again. Well, I notice you are eating something with color. Well, that's nice. Nice orange color. Wait a minute. Is that a Cheeto? You trying to trick me into think you're eating something with phytochemicals and you're eating a Cheeto? Trying to make me think you're eating a carrot while you're watching this. Well, you can't fool these eagle eyes. I can see ya. Anyway, we're going to continue our conversation on carbohydrate health concerns and look a little bit more closely at specifically diabetes and hypoglycemia. So we'll get right to it. All right, so the two main types of diabetes we're going to talk about are type 1 and type 2. Now, type 1 is normally occurs when people are young, and it normally seems like it occurs very rapidly. As you know, one day you don't have it, the next day you do. You get the feeling, feeling kind of goofy, and you go to the doctor, and there you go, you got diabetes. So it's very brittle. What that means basically is when you get type 1, sometimes it's pretty difficult to get it in control because the sugar levels just kind of bounce around, and you can't get them dialed in. So it can take a long time to get them dialed in. That's what I was kind of talking about in the last session about, if it happens in younger people, they get pretty discouraged and pretty upset and angry about things because it's pretty difficult sometimes to get this into control. And sugars just seem to jump around. You think you got it dialed in, and then no, you don't, kind of a thing. But I do want you to know, because we're talking mainly about the nutrition aspects of this, that there is nothing anybody can do nutritionally to cause themselves to get type 1. Type 1 is an autoimmune disease. In some sense, it's genetically based. Some people are just more prone to their immune system being stimulated to destroy the beta cells in the pancreas. So it doesn't matter. You might hear, well, if you eat too much sugar, you're going to get diabetes. Well, not type 1. Or if you do this and that, you're going to get type 1 diabetes. Well, no. It's just one of those things that some people are more prone to other ones to get type 1 diabetes, and it is genetically based. So nothing you can eat or drink or anything that would increase your risk of type 1. It does seem that to get type 1, some type of an event has to occur that kind of stimulates your immune system. Whether, some people, they get a cold with a fever, or they're under really high stress for some reason. Something's changing. There is some evidence that it could be a virus that infects the beta cells of the pancreas, and your body says, well, there's a virus I need to get rid of, and the only thing it can do to get rid of it is destroy the cell. And so you start destroying those cells and reducing the amount of insulin that's produced. So there is some evidence to that, but in any case, there has to be something that sets off your immune system to get it going and doing that. You can get an indication as type 1 because it is, you do produce antibodies, so it's an autoimmune. So you can see I've listed, I don't expect you to know all of those. It's not that important for us, but I just wanted you to know that they can do some testing to see if antibodies are being produced. And if they are, then it would be a good indicator that it's type 1, not type 2 diabetes. So the idea of these insulin transporters, I think I mentioned it maybe earlier, is that the insulin will fit into a receptor You will then activate the movement of the glucose transporter. In this case, you see it's GLUT4. To become embedded into the plasma membrane. And then by facilitated diffusion, glucose will come from the blood, high concentration in the blood, to a low concentration in the cells. It just needs a way to get through, and so these transporters allow it to a channel, so to speak, to allow the glucose to get through. So insulin is going to stimulate the GLUT4, embedding it into the plasma membrane, because I think I mentioned before, cells can add or delete proteins in their membranes as needed. And this is another idea. If you see that you have diminished insulin, it has nothing to do with the receptors on the membrane. It has to do with how many insulins you have that can fit into the receptors to stimulate the transport of the, well, I should say the movement of those transporters to the plasma membrane. So if you don't have a lot of insulin, you're not going to get any movement of those transporters, so glucose cannot get through the plasma membrane out of the blood. So that's the whole idea. Now, type 2 is more of a gradual onset, meaning that you can see trends. This is where pre-diabetes would come into play for type 2 diabetes, is because you can see that the sugar levels are rising over a period of time. So that's why they gave it a classification of pre-diabetes, which is more often related to type 2, not type 1, because remember, type 1 is more rapid onset. But normally it happens in individuals over 35 or so, but that's becoming less and less true. There's a high incidence increase of type 2 diabetes in adolescents. And we'll talk about that, why, in just a second. So it's becoming more and more that what used to be called adult onset is not true anymore. It's becoming more and more younger. And I think, as I recall, the 30s, and I think the average 33 now is the average age when people might get diabetes, and that age group is increasing in a rapid pace. But the idea is you get a progressive loss of beta cells, or you get what's called insulin resistance, which can be a function of malfunctioning cell receptors, or what we'll call post-receptor defects kind of thing. Anyway, one of the risk factors for type 2 is gestational diabetes, which is something that occurs to some women during pregnancy. And it has to do with the hormonal change, and it sometimes doesn't necessarily have to be specifically with insulin. As you remember, GLP-1 is going to stimulate the beta cells to produce insulin. And so it may not be a beta cell problem, it may be a GLP problem, or amylin could be the problem. So but the hormones are causing some disruption in the ability of the body to regulate glucose. But what they found, the correlation is that women who have type 2 diabetes are at a higher risk for women who have gestational diabetes are at higher risk for getting type 2 later on in life, because normally after birth the diabetes goes away, but the red flag would be that you need to watch later on in life, because you're at a higher risk than someone who was pregnant and did not have gestational diabetes. Okay. The big risk factors for type 2 are the big risk factor is obesity. Boy, I can't talk today. Is obesity, what we call visceral obesity, or you might hear it in other places called central obesity. but I like the word visceral because it deals with fat in the viscera, in the intestines and around that area. Um, Visceral obesity can cause several changes that can result in type 2 diabetes. The one you hear most common is insulin resistance, and that can be caused, there's two categories that could be referred to as being insulin resistance. One is where the insulin receptors don't work. Something genetically is wrong, or something has happened that you don't make these insulin receptors, and so you have a reduced amount, which means you're going to make a reduced amount of glucose transporters being embedded in the membrane, and so you don't get the sugar out as fast of your blood. So that, if that maintains it in long term, then you would be classified as having type 2 or high sugar levels most of the time. Now, post-receptor defects mean that the receptors are fine, but there's a signaling pathway that is going to send the signal from the insulin receptors to the inside of the cell, the cytoplasm, that would basically cause the movement of these glucose transporters to the plasma membrane. And so there's a defective signaling to those transporters, so they don't move. So that's after the fact. So there's not a problem with insulin, there's not a problem with the receptors, there's a problem with the signaling inside the cell. The other one is impairment of insulin secretion, which I like to refer to as pancreatic exhaustion, and I've read this before, because what happens is this normally happens kind of later on in life, because it's determined by whether you get pancreatic exhaustion is determined by how long you've been obese, not how obese you are. So it's more of a long-term thing where it's kind of equivalent to driving a car 100 miles an hour all the time, and stressing the car engine, and pretty soon it says, I give up, this is it, and it goes zonkers, blow a head gasket or something. Well, that's the same thing with the pancreas. Is if you've been stressing those beta cells for so long because of all the food you've been eating, pretty soon they're just going to give out, and you will start decreasing their mass, which means you're going to reduce insulin, and at that point you could become a type 1 diabetic, because if the beta mass is low enough, then you could get type 1. And so this is also maybe an effect of the trend, or you'll start seeing less and less insulin produced. And they can test insulin levels too, if they wanted to. They could take a test and see how much insulin is being produced, kind of thing. And the other one is, I don't know, it's one of those that is a possibility, and I'll show you a picture of that. But it has the idea of, if you have receptors on the plasma membrane that are going to receive the insulin signal, but those receptors, as the cell size gets bigger by adding more fat as you get obese, then those receptors are going to change their shape. And when they change their shape, they may not accept insulin anymore. Because there are times, quite often, where a type 2 diabetic can lose weight and not be type 2 anymore. So that may be because of the cell size. It was really big while they were obese, but it shrunk down, and so now the receptors are the right shape, and they are able to then receive the insulin and do that. So those are four. Let me show you some pictures that kind of relate to those things. So here you can see the faulty insulin receptors. You can see on the top picture, in normal cell, you can see all the receptors are working fine, the insulin fits in there, and then the glucose is transported in, and no problem. But if you look at the bottom picture, you'll see that some of the the insulin receptors aren't functional. And so if they're not functional, they don't receive the insulin, and so you're not going to transport. So, you can see you can transport a little bit of glucose, but not enough to keep you from being hyperglycemic. So that would be the faulty receptors. Post-receptor defects, now this would be where, again, the insulin, as you can see, is fitting into the receptors. The receptors are fine, but there's a defect in the signaling to the GLUT4. So the GLUT4 is not going to be transported up to the plasma membrane, and so you are not going to be able to take up as much of the sugar as possible, and so you will get type 2 diabetes, right? So that's another form of insulin resistance. So one type is the insulin receptors don't work, so you don't receive the insulin. The other one is the insulin works, but it doesn't send the signal to move those receptors. So this is just the same picture, but you can see, remember we said the GLUT4 is going to be embedded into the membrane and move the glucose. But here's something from Endocrine Reviews. It says, the developing pictures, the keywords are the free fatty acids. If you remember the visceral obesity, the fat is right next to the intestines, and you have the hepatic portal vein. If you have an anatomy book, or if you've had anatomy, maybe you remember that the hepatic portal vein is going to come right off of the intestines. So during absorption and stuff like that, the nutrients will go right into the hepatic portal vein, and because it's right next to the intestines. Well, that's going to be the same thing with the fatty acids. If you start breaking down fat in the visceral region, then those fatty acids are going to go directly into the hepatic portal vein, and they're going to accumulate to toxic levels. And as you notice that at the bottom couple sentences, it can contribute to beta cell failure and the development of type 2 diabetes. So it's the free fatty acids that are the issue here with obesity, because normally visceral fat is used first before subcutaneous. And so if you have a lot of visceral fat and you're losing weight, or you need it for energy, it's going to come from there. And this is some busy slides, but I hope you get something out of it. I don't expect you to memorize these or anything, but you can see an adipose tissue at the top there. And then it goes through lipolysis, which means you're breaking down the fat for energy, but you're going to increase your free fatty acids, FFA, and you notice that it increases oxidation in the liver, in the muscles, and you're going to decrease glucose utilization in the muscles. You're going to increase gluconeogenesis, which basically means that the liver, because you're not taking up as much glucose in the muscles, the cells are going to be saying, wait a minute, we don't have enough glucose. Liver, would you please break down some of your glycogen and put some glucoses into the blood? And so that's the neogenesis. Neogenesis means the beginning, the new. And so they're making new glucose and putting it into the blood. So that just increases, both those things together increase hyperglycemia. Another side, you can see on this side, beta cell dysfunction, where the pancreas is being degranulated, and that can be because of the free fatty acids that are being produced, and so they will become at toxic levels. They will start reducing beta cell function, reduce insulin, leading to hyperglycemia. The liver is going to increase glucose output and hyperglycemia. And then, this kind of has to do with elevated plasma free fatty acids. So it's pretty complicated, but in any sense, what the theme we're trying to promote is, visceral fat is not a good fat, right? And so it needs to be taken care of because that's going to cause some issues not only with diabetes, but we're going to see it in cardiovascular disease as well. And this is just another slide just showing you that idea of obesity. You can see here's the weight gain where we go from a normal sized adipose tissue to larger adipose tissue cells because we're getting more and more fat incorporated into those cells. And you can see what can happen: oxidative stress, endoplasmic reticulum stress, free fatty acids, lots of things. Down here, we have these pro-inflammatory markers, pro-inflammatory things that are being produced, and they will then, increase chronic inflammation, which can also lead to the insulin resistance and destruction of beta cells and those kinds of things. So what we're saying is adipose is a living tissue, and when it gets stressed, which basically means that you're filling it up and it's getting too full, then it's going to start becoming inflamed. You can see adipose tissue inflammation and insulin resistance, and so that inflammation is going to produce these inflammatory substances, and that's not good. And then here's I put this picture up here just to kind of look at, but the caption is adipose tissue obesity is a chronic inflammatory disease. Obesity in the visceral fat induces inflammatory cascades. Again, just reinforcing this idea of visceral fat is a not a good thing. And then another one just saying, relating to system insulin resistance, kind of a thing. So, and I wanted to get another one to just kind of show you, and hopefully you have had some cell biology and you remember the idea of the endoplasmic reticulum and what it does. I'll kind of review that a little bit. But here's, as you can see, here's the cascade we've been talking about. Insulin fits into the receptor, and you can see all these things cascade. Then we go to this next slide, and what you can see is the stresses from obesity. The TNF, this is an inflammatory signal, tumor necrosis factor that's produced, and then the excess fatty acids that we've been talking about, and the endoplasmic reticulum. If you remember from your biology, and you might take a look, the endoplasmic reticulum is the one that folds the protein. If you had some chemistry and cell biology, you'll remember the ribosome is going to put the amino acids together and formulate the primary protein structure. But then it inserts that primary structure into the rough endoplasmic reticulum, and inside the rough endoplasmic reticulum is where you're going to fold the protein into its secondary tertiary structure, put identification markers on there, put it in a vesicle, and then it's going to be sent to the Golgi body. Okay. Well, what you notice is this stress, and we're talking about insulin resistance signaling effects. So you can see the stresses, and it stresses the endoplasmic reticulum, and you notice down here it says unfolded protein response, which means the proteins that are necessary as part of the signal cascade are not being produced properly. And so if you go up this signaling up here, you'll notice that it says the serine is inactive, and so there's no phosphorylation or activation of this part of the signal here, and you'll notice over here there's no GLUT1 to the surface. So again, just looking at the stresses of obesity that is messing up the system inside the cell, and so this would be a post-receptor type of defect that would not allow the glutes to go to the surface, therefore type 2 diabetes. And here's pancreatic exhaustion, where you can go with a lot of beta cell granules, and now you have beta cell burnout. What they say, we're going to call it exhaustion. And again, this is a result of how long you've been obese, not how obese you are. So it's more long term. It may come at a older age kind of a thing, but it can happen over time. Um, and then here's the increased size option. And I couldn't find a good diagram, but this kind of indicates, if you notice here, we've got two parts to the insulin receptor. Okay. And so when the insulin fits in here, these two come together, and then you start sending these signals, and then you get the GLUT4s that were embedded into the membrane. Well, if you think about the distance that these are apart, okay, and then you start increasing the size of the adipose cell, these two can get further apart as the cell gets bigger and bigger. Like you would have a face on a balloon, and as it gets bigger, the face, kind of expands, kind of thing. Well, sometimes, the theory is these two get too far apart, so then they can't come together. And so then you would not send a signal, because you need them both phosphorylated and they send the signals and all of that thing. But if you were to lose weight, then these come back to their normal distance apart, and then they can come together. So that's kind of one of the theories about increased cell size. Looking at that, there is a type 1.5 diabetes, and you see the other names that are possible: mature onset diabetes of the young, latent autoimmune diabetes in adults. But it's kind of a mixture of a type 1 and type 2, and as you notice down at the bottom, it's often misdiagnosed as a type 2. Because they don't test for antibodies. So some of the symptoms are the type 2 is that insulin is still being produced. Unlike type 1, it's still being produced, but it gradually goes down, and in 5 or 10 years, but you're producing antibodies. So it's starting to affect these. So one of the things that, I don't know if doctors regularly do this, but might be a good option, is if they notice that you're still producing insulin, but you have the symptoms of diabetes, you might want to do an antibody test to see if you're producing antibodies. It's because that would be an indication of an autoimmune situation, kind of a thing. So anyway, that, every once in a while, so I don't know if you have somebody that's been diagnosed as type 2, you might see if the doc did an antibody test. I don't know if they regularly do that, or if they can, maybe there's something else that they do to weed out the possibility of it being a type 1.5. I just wanted to show this chart at the end to just show the increase of type 2 diabetes. Type 1 is pretty level. It's, between 5 and 10% of the population, but type 2 is just growing like crazy. Once again, I probably mentioned it earlier in the last session, but there doesn't seem to be any indication that it's going down without medications. Right, and so you have a higher incidence of newly diagnosed type 2 diabetes, and it just seems to be increasing, and there doesn't see any indication that it's going down or going to go down in the near future. And it all has to do with obesity. The major risk factors that visceral obesity, and obesity is continuing to rise. Right. Now, diabetic complications, I do want you to relate hypoglycemia to insulin shock. Now, hypoglycemia, as you know, is low blood sugar, but sometimes referred to as insulin shock because it has to do with too much insulin. And it could be that somebody, takes a double dose of insulin. You know, some of us would wonder, you know, if you're giving yourself a shot, how would you ever not know you gave yourself a shot? Well, if you've been doing it for 40 years and you wake up kind of groggy and you just go in and kind of take a shot and then you know, eat breakfast, you say, oh, I better take my shot before I go to work, and you take a double dose, you know, kind of thing. I don't think that probably doesn't happen often, but I can see it possibly happening as you get older and you get very forgetful, kind of a thing. Or if you take your insulin, you don't eat any food. I mean, insulin is going to work no matter what. It doesn't really care if you ate food or not. It's going to take glucose out of the blood, right? And so if you don't eat, it's just going to take whatever glucose is there and start taking it out, and then you could get hypoglycemic. Now, hyperglycemia, ketoacidosis, is obviously you're producing ketones because your body's not able to use glucose. And that could be because you're not taking insulin. I mean, this would be the most often for pre-diagnosed diabetic, someone who doesn't know they're diabetic, most often would be hyperglycemic. And they'd have high ketones and, you know, decrease insulin. But it could be if you eat too much. If you go out to a party and eat too much and you don't take a dose of insulin. A lot of diabetics, at least one that I knew, basically, if they're going to eat spaghetti or something with a high amount of carbohydrates, they just give what's referred to as a bolus of insulin. They'll just take an extra hit right after the meal to take care of that carbohydrate. Because, well, I guess mainly because they want spaghetti, you know, they like spaghetti, they're not going to give it up, so they'll just take an extra dose of insulin. But you know, you just hope they know what they're doing, kind of a thing. And he's in his 70s, so he's been diabetic for a long time, so he seems to know what he's doing. But anyway, but if you increase your food or you don't take your insulin, maybe you wake up in the morning and get an emergency phone call and you just forget, and because you got to run. Well, you know, about 10 o'clock, you might start feeling the symptoms. You know, if you did eat on the way or eat, that kind of thing. So anyway, so I do want you to know hypoglycemia associated with insulin shock, hyperglycemia with ketoacidosis. Here are some of the goals for medical nutrition therapy for diabetic. Glycosylated hemoglobin, or what we call A1C, you know, less than 7 if possible. Preprandial and postprandial. Preprandial means just before you eat, like, you know, you take a test before you have breakfast, kind of thing, and see where your blood glucose levels are. And then postprandial is like 2 hours after you eat to see where your blood glucose levels are. So you'll take a test, you know, and this happens a lot with newly diagnosed diabetes. They kind of need to know where they're at before and after to see what foods they're eating and how they're affecting the sugar levels. So they will take a finger prick test, you know, and before breakfast and then after breakfast and then maybe before lunch, after lunch, before dinner. And so they'll do it several times. And your fingertips, you know, used to be, they probably have better tips now, but they used to be, they get very tender because you keep poking them. But those are kind of the indicators. Now, the LDLs are low density lipoproteins and HDLs and stuff we'll talk more about with cardiovascular disease. So in this section, I don't expect you to know what they are or whatever, but after we get done talking about the lipoproteins and cardio, you could come back to this and this will make sense to you. But anyway, the idea is that, and we talked about last time, it's the risk factors for diabetes are really high. And there's a higher risk, like 400 times risk for heart disease, then your markers for risk for heart disease need to be lower. So the LDLs, low density, HDLs, the triglycerides, and blood pressure, all of that are pretty regulated compared to the population that doesn't have diabetes. So anyway, so we'll know more about those later on, type of thing. Okay, so hypoglycemia. So hypoglycemia is low blood sugar, and that's around the 40 to 50 range. Remember, the normal is 70 to 100 is where they'd like it to be. But if you get down to 40, 50, you can start feeling symptoms, and I'll show you what they are. But it could be caused by stress. You know, there's some cases where stress can cause that, and that's where we were talking about the adrenaline earlier in the last session. So anxiety, tension, and those kinds of things can bring it on. But the worst case scenarios could also be a pancreatic tumor. So this is not a condition you want to self-diagnose. There are some individuals who do self-diagnose, and they'll carry around some sugar pills like dextrose or something, or they'll carry around lifesavers, kind of a thing, and they will. When they feel the symptoms, they'll just take a hit. But the problem is, like it says in the bottom, this is not a disease. It's a manifestation of something else that's going on. So people who have hypoglycemia really need to get diagnosed. They really need to go in and see what the primary problem is, not just treat the symptoms. Okay, so if you have friends or anybody you know that says, yeah, I'm hypoglycemic, every time I get this feeling, I just take a sugar pill and it goes right away. Well, that's true, but that isn't solving the problem. That's just putting a Band-Aid on a real problem. Okay. There are two types I want you to know. One's called reactive, and reactive basically means that you eat a meal, especially if it's high in carbohydrates, and especially again if it's high in refined sugars like punch and cake and with icing and all that kind of stuff, a bunch of ice cream or something, and then about 2 or 4 hours after you eat that meal, then you get the symptoms of hypoglycemia. It could be one of the etiologies, could be an overproduction of insulin, but it also could be, something else underlying. But if you had an overproduction of insulin, which, we all have glitches, and that's just a glitch that some people have, right? And so if you, again, the insulin is going to work no matter what, and it's going to take sugar out. So if you overproduce, you could become hypoglycemic. But this is reactive is short term, 2 to 4 hours. Now fasting is more long term, so it's 8 to 24 hours. So it may be one of those where you eat something high in carb at night, and then in the morning you feel the symptoms because it's been a while. This could also be overproduction of insulin, but where the real concern is, as you can see, is the pancreatic tumor. That is a possibility. So that's the real concern with that one. It's a little bit higher. The symptoms of fasting hypoglycemia are a little bit more severe than so here are the symptoms. The top ones are basically the symptoms for reactive, and they don't go down into the bottom set of pictures. But I don't know if you've ever felt these symptoms. When I play basketball or something like that, sometimes, and it maybe happens once, twice a year or something like that, I'll just feel goofy. I'll get a little bit shaky. It's not like shaky, like real shaky, but you just feel a little irritated, kind of shaky, sweating a little bit. Your palms kind of sweat a little bit. You feel a little anxious. There's the hunger piece is it's not a painful hunger. It's more of a butterfly, tickly hunger, like the feeling you have before an exam in your stomach. It just kind of feels goofy, that kind of thing. And so, if you get something, sugar or something, it'll go away. Or if you just sit down, sometimes I'll just have to sit for a second and it'll gotta go away. But the bottom ones, the top ones you can get with fasting, but the bottom ones are a little bit more severe. So your heart rate goes way up. You sometimes get goofy vision. You can even get mumbled speech, incoherent speech, weak, headaches, irritable, those kind of things. So it's a little bit more severe. And so if that happens often, I mean, if these conditions happen often, then you need to get them checked. If they happen every once in a while, once or twice a year, then probably not a big deal. But if it's a usual occurrence, especially after high carbohydrate meals, then you need to really get that checked. So what is the nutritional care plan for a diabetic and a hypoglycemic? They're basically both the same because you're in both cases you're dealing with a goofed up glucose regulating system. We did an assignment on carb counting. So carb counting would be what a diabetic would be taught to take home with them. This would be the plan that they would take home and try to use. So normally, if you're diagnosed as diabetic, the dietitian and or the nurse, because you can, in most cases in hospitals, and I know they do in the Dalles and Hood River, they have diabetes educators, and they have a nurse and a dietitian who's part of that team. The dietitian is the one who talks about the diet and all that kind of stuff, and the nurse is the one that helps with insulin injections and talks about the medications and stuff like that. So if some of you are going to be nurses and are interested in diabetes, then you could become a diabetes educator. It takes a little bit more education. I mean, you have to take a test and you have to get so many hours, patient contact hours in diabetes and that kind of thing. But anyway, so the dietitian is going to teach the patient plus whoever else is in the household that might fix food about how to do carb counting. And you'll know after you've done the carb counting, if you've done it already, that it's not followed very religiously. Only about maybe 30% of the diabetics actually follow it to some extent. The other ones basically trash can it and say, I can't do this, it's too regimented. So anyway, but that is the protocol for what the dietitian would want the diabetic to know what they should do with their eating. The glycemic index and glycemic load, these would be mostly used by a health professional or dietitian to look at the patient's diet and see if they can make any recommendations for changes for that individual. The glycemic index is an index that was put together by taking white bread and feeding it to thousands of people and then checking their sugar. I mean, they check their sugar levels before they eat the white bread, and then they eat the white bread, and then they check their sugar levels after, like postprandial, after they ate the white bread 2 hours after, and see where their blood sugar levels is and see how much that white bread raised the blood sugar levels. So then, after they did this research with thousands of people, then what they did is they put together an index that said, okay, this is our base number for white bread. Anything over that number, we're going to say has a high glycemic index. Anything under that number, we're going to have a low glycemic index. And I've seen glycemic indexes of where 100 was the parameter for white bread, and then I've seen other ones, and I think I show you this one. Next one is 70, so it just depends. But that isn't sometimes just knowing the glycemic index of a food is not a good indicator as to whether it's going to raise your blood glucose a lot or not. The other category that needs to be part of that is the glycemic load. The glycemic load is going to determine how much your blood sugar is going to be raised, not how fast. So the glycemic index is basically how fast and how high, but glycemic load is basically going to indicate, okay, basically how important is the carbohydrates in that food in raising your sugar levels. So I'll give you an example. So here's a chart that kind of shows you the relationship with the glycemic index and glycemic load. You'll notice up the top it has the categories. You have the food, the glycemic index, and the glycemic load. And what you notice is here the baguette has a very high glycemic index. Down here you see the index, and basically what they're saying is 70 is the white bread index, and anything over that is high glycemic index, and below that is lower. But you'll see that baguette is above 70 at 95. So you would recommend, if a patient likes baguettes a lot, you'd recommend that they maybe reduce serving size of those because it's going to raise their blood sugar pretty high. But you also notice that watermelon is above 70. And so, what are we going to do? Tell the patient, we don't want them to eat watermelon? That seems kind of ridiculous because it's, a fruit kind of a deal. Well, that's where the glycemic load comes in. You'll notice down here, if you're above 20, that's considered high glycemic load. And you'll know the baguette is 48. So baguettes are ones that you'd really, ask the patient to really be careful how much they eat of those. But you'll notice the watermelon is 3.6. So even though the sugar in the watermelon is going to get into your bloodstream very quickly, there's not enough sugar in the watermelon to make a significant difference in the blood sugar level. Okay, now the baguette's going to get there fast and it's going to raise it pretty high. Watermelon's going to get there fast, but there's not enough to make a difference. So you would tell the patient that's fine, watermelon's fine, kind of a thing. So there's whole text, there's whole indexes and textbook index type thing of all the foods. So this is what you wouldn't send the patient home with trying to figure out the glycemic index. What the dietitian would do would, do a patient food intake and then look at the food that they normally eat and compare that to a glycemic index, and then go back when they're counseling the patient and telling them, hey, this baguette is really going to raise your blood sugar. I know you eat it a lot, but if you could reduce the servings amounts per day, that would be do you a lot of good. Baked potatoes are another one. You might, if you ever want to have time and are interested, you look at the glycemic index and you find that baked potatoes tend to raise blood sugar pretty high. It has a high glycemic index and glycemic load. So, and then there's combination foods. I mean, what would a pizza do? So they have all that. So anyway, so that's the difference there. Protein, a little bit higher protein because of the immune system and a little bit compromised. Lipids are low, they're at least 30%. They'd like them to be down to 20, but saturated fats and stuff, they're pretty well monitored. Again, their relationship with heart disease. Multiple feedings per day, like you did on your meal plan, 6 to 8 meals per day, because again, you want the sugar to just be gradually go into the bloodstream, kind of even all day long, not a big rush at one time. Because I mean, think about it, if you over secrete insulin and you get a big rush of sugar, that might be a real problem, because your pancreas is producing too much already. You get a big rush, it's just going to really produce it, and so you could become hypoglycemic or something like that. Reasonable weight, and then the alcohol limit is there. All right. And lastly, says 50, fat, diabetic, ahead of you. That's good. All right, so we will get back to you later and talk about something new. All right.